you. We move on to our next speaker. Our next speaker is Dr. Dr. Rakhi. Dr. Rakhi, all of you know very well. She's a cataract surgeon and also she's a very dynamic speaker. She's a part of multiple national and international conferences. So, Dr. Rakhi will be speaking on taming the polar bear, okay, the PPC cataract, which all of us need to be very well prepared and manage well. Yeah, over to you, Rakhi.
Good morning, everyone. So, I'll be talking on posterior polar cataract today. So, the objective for this presentation is to recognize why posterior polar cataract has a high risk and to learn some low stress techniques which we can use for the safe management, the do's, the don'ts and the bailout tips if PCR occurs. So, studies report that the chances of PC rent is around 20 to 36% in posterior polar cataract. 26% of them can have a pre-existing defect. This pre-existing defect can be missed if we have a mature cataract and we are unable to see the status of the posterior capsule. So you need to anticipate that there can be a posterior polar cataract in cases that are so mature. If the other eye is unoperated, look for the other eye and see if there is any PPC in that. If the other eye is operated, you have sometimes might miss this. And the another thing is that 40% of them can develop intraoperative defect. While you are doing the surgery, before that there may not be a defect, but doing the surgery, there will be a defect. Because the posterior capsule in these cases are pre-weakened, they are dehiscent. So even the normal forces can lead to rupture of the posterior capsule. So what all we can look for? In the slit lamp, look for a classic onion peel type of posterior polar cataract. But sometimes, many a times, you may not be able to see such a beautiful crystal clear posterior polar type of a cataract. What will be there? There will be some other signs, like there it will look like a PSCC, normal PSCC, but some demarcation and a sharp thick margin will be there. It will look like a PSCC with a centrally little harder plaque, but with some vacuoles nearby. Sometimes it will look like a PSCC only, but some white spots at the edges. Maybe you can see some oil droplet like things or shining things in the immediate vitreous. Or maybe there is some white dots in the vitreous that will move like a fishtail sign. So, Minimathan sir was telling the last day that in cases of posterior subcapsular cataract also, whenever you see there is a thickened plaque along with the posterior subcapsular cataract, even though it is not looking like a pakka PPC, still you anticipate, you just have in your mind that it might be a PPC and go into theatre prepared. Imaging optional but useful ASOCT. Counseling the most important part. You need to tell that there is high risk of PC rent. It is because of their own eyes pre-existing defect. Chances of vitreous loss. You need to be prepared for an anterior vitrectomy, a secondary IOL, and there can be a chance of NDA capsulotomy later if there is a residual plaque. So the most important pearl coming to managing a posterior polar cataract or an anticipated posterior polar cataract is keep a low bottle height, moderate flow and vacuum, and avoid sudden surges. So in order to avoid the sudden surges, you need to maintain the AC with a cohesive plus a dispersive OVD. Incision standard clear corneal, but ensure that it has a good construction to avoid any leakage or chamber collapse. Fill with cohesive OVD for capsular excess or do a soft shell technique. Capsular excess should be round, well centered 5 to 5.5 mm for a future optic capture if needed. Some of the surgeons prefer an oval capsular excess in these cases. Hydrodissection, the golden rule, gentle hydrodelineation alone, no dissection. Inject the fluid centrally. Like what we do, we normally go to the 4 o'clock and 8 o'clock position, but in this case be central, gently, low, short volumes, watching carefully for the golden ring. Many surgeons prefer multi-quadrant hydrodissection with tiny amount of fluids, and alternatively you can also visco-dissect the cortex or epinucleus instead of the BSS to avoid hydraulic blowouts. Try to keep that epinuclear shell as long as possible. So, we all will be very familiar with the inside-out delineation which was taught by Dr. Afay Vasavada. So what he does is, first he does a central sculpting, only sculpting, little bit of sculpting, and then he takes this bent cannula and does the surgery. Let's have a look at it.
Illustrates that with the bent cannula, you can decide what level, anterior posterior level, you want to penetrate and generate demarcated central nucleus, and you can repeat this on the other side.
So it was a central sculpting first, then taking the bent cannula a little bit inside and then doing
Illustrates that
hydrodelineation. Another important and famous technique is the multi-layer delineation, which was by Dr. Gulani. Here he is going into multiple levels and doing hydrodelineation in multiple levels. So what happens is the central nucleus pops up. So it is very easy to take it out and eat it first. Then you can deal with the posterior plaque later. So the nucleus management, the more common text is inside-out delineation, which was popularized by the Afay Vasavada. Modified stop and chop, V chop is there, in which the central sculpting is done in a V shape, and then you eat up the central nucleus and then go for the remaining epinuclear shell. Similar thing is lambda, where the central nucleus is first chopped like a lambda and then go with the central sculpting. So phaco chop, always maintain a low vacuum with minimal rotation. Epinucleus also go for a low vacuum and low flow. Pull the material centrally, avoid the stripping forces tangentially. Cortex aspiration, bimanual IA or a manual dry aspiration with Simcoe. Low blow till height and low flow rate. Pull the cortex tangentially, not centrally. Avoid polishing because this has a very delicate posterior capsule. Whenever there is a dense posterior plaque, don't try to be a hero. You can treat it later with the ND-YAG capsulotomy. So this is one of my videos on how I deal with posterior polar cataracts. So I usually prefer the multi-layered, multi-quadrant hydrodelineation. You can see there is 2 rings and I don't rotate, only the central sculpting in the V-shaped manner. Then usually I use a second instrument a lot. Along with that, I do this remaining layer by layer phaco. And for the posterior plaque, I usually keep it towards the last. Aided by the second instrument, I lift it up into the central AC and then eat it up. Then sequential epinucleus removal. All to be done under very low parameters. And make sure once you are removing one instrument, always inject visco because you don't need the AC to be, you need the AC to be maintained throughout the surgery and avoid polishing in these cases. So just to reiterate, don't perform routine forceful hydrodissection, don't aggressively rotate the nucleus, don't strip the cortex vigorously, and don't do polishing. And don't let the anterior chamber collapse at any point of time. Slow instrument exchanges, OVD refill before removing props. Do have the vitrectomy and sulcus compatible IOLs ready. So if you have a PCR, early recognition is the best. Immediate steps, we all know, stop the phaco, foot pedal to irrigation only, inject dispersive OVD through the side port to tamponate the rent, maintain the space, stabilize remaining lens material, avoid fishing of fragments. For vitrectomy, perform an anterior vitrectomy with a high cut rate and low vacuum and use triamcinolone if you need. IOL decision, if you have an intact capsule, place a standard IOL in the bag, ensure good rhexis, optic overlap to reduce the risk of decentration and further PCO. PCR with a good anterior capsular rim, go for a 3-piece with an optic capture. Big defect, opt for iris claw lens or scleral fixated lens. So just to conclude, respect the capsule, not the clock. Slow, deliberate surgery is safer than the fast routine phaco. Avoid routine hydrodissection, rely on hydrodelineation or viscodissection. Low parameters throughout, maintain the epinuclear shell as much as possible. Always be prepared for the PC run with vitrectomy and secondary IOLs. And now a simple, safe bailout plan is appropriate for all of us. Thank you.
So thank you, Rakhi. I think it's your very comprehensive talk. You have covered most of the points about PPC. I just have one question for you. If you have a list of say 4 or 5 cases, then which case would you, at what order would you place PPC?
Usually, I always keep all the complicated cases first.
First.
Yes,
Okay.
because I want my mind to be clear.
Okay. So, will it be like, okay, the other patients will be complaining just in case something happens in the beginning?
That has to be anticipated. We have to inform them.
So, okay. So you prefer it first?
Yeah, I usually prefer all, especially if PPC is there in list, it will go first if there is no torics.
Okay. What about you, madam?
Same. Any complicated case, any high risk case, any VIP case first. Probably you are more perceptive, you are more prepared, you are into a good mood. And I think if you do very good this case, your whole list goes smooth. Otherwise, when you are doing a normal case also, your mind is always with that high risk case.
What is
that
going to
PPC
happen?
Case. So it's, I think, individual choice how will you deal with. But then when you are into a theatre for your first case, you are more prepared for everything.